My name is Christoph Naber. I'm here for ESC TV, and I'm together with Dr. Abizaid from Brazil and Dr. Dangas from the United States. So Alex, maybe you can tell me, we are talking about TAVI today, and maybe you can tell me, after so many implants, isn't TAVI pretty much a routine procedure?
So Chris, I think that for high-risk patients, there is no doubt that TAVI is the default therapy today. I think that we still have some doubts and debate whether we should move to intermediate risk patients. And as evidence will be built in the next few years, I think that naturally we're going to move towards that direction. We have partners 2 with 30 days follow-up. Soon we're going to have the long-term follow-up. TAVI here in Europe, comparing against surgery for lower risk patients. I think that the big debate and the big challenge will be reimbursement. As we embrace more patients and as we treat less sicker patients, I think that the governments will have to find ways to reimburse for these procedures.
So with less sicker patients, less risk for the patient. George, any views on that?
I agree completely. This was a very good point. I just want to also say, though, that there are certain sites or certain areas that they haven't really started with the program as much. And when we reflect all these ideas of routine procedure, etc., the technical part is routine. I think for the sites that have done a lot of procedures over the years, they have coordinated the team, surgeon, interventionalists, radiologists, anesthesiologists, ICU. It's still, I think, not routine if someone wants to just start now. But I think it's heading that way, and clearly the well-oiled machines are able to do more things from technical point of view and device point of view on a relatively routine basis.
Yeah, I fully agree, and this brings us to a point, to the question, do we really always know what we are doing? For example, adjunctive pharmacotherapy. Is this something where we already knew what we do?
Well, that's a good point, but don't we always know what we do until it changes? Probably something like that as well here. The TAVI arena or field started up wanting to bring some devices to show feasibility, etc. There were really no data about pharmacology. We extended what we knew from coronary or from maybe valvuloplasty, and we kind of developed evidence-based recommendations, and that is really reflected in the current guidelines as well. They're all evidence-based C. There's not any randomized body of evidence in this area. So I think that's going to probably have to improve. One of the challenges of the procedure is the bleeding, is also some ischemic complications, either cardiac or cerebrovascular combination. We don't exactly know their time frame. Antiplatelets have a role. Antithrombotics may also have a role in order to mitigate further the thrombus in the valve, and both are going to be tested in randomized trials prospectively, because there's always a safety question. And how do you balance the benefit versus potential risk when you move into a little bit longer term administration?
But these trials are run currently. I mean, you are starting the Galileo trial, and I think this addresses one of these questions, for example.
Yeah, this is correct. This is going to be the first study of the randomized study after a successful TAVI procedure that will test dual antiplatelet therapy versus a combination of low-dose rivaroxaban for the venous thromboprophylaxis, thus far really 10 milligrams only plus aspirin. Okay. And then we follow up the patients and act accordingly as they go. Okay. And we just completed the Bavalirudin study in the acute cath lab. We'll learn about that in a few months.
We hear the data soon. Very short question, very short answer. So the ideal TAVI device that is upcoming, which questions does it need to address?
Oh, that's a great question, but not so quick to answer. I think that we still have to target and nail some of the complications that we still see. There is no doubt that there was a huge development in this past decade with the current devices that we have, but they're not perfect yet. I think that we still live with a good number, a good percentage of patients with paravalvular leak, with the need for pacemaker. Durability might be a question. Maybe with some new drug regimens, we're gonna really eliminate the possibility of thrombosis or durability in the future. So I think that there is still some unmet needs, perhaps bleeding from the access as we decrease with the profile. So I think that I'm not sure if we are totally 100% happy with the current devices, despite the development.
Ladies and gentlemen, it's already time to summarize. I understand that TAVI is still not a routine procedure. It is for many patients, but there are still many open questions that we need to answer. We need still to understand the adjunctive pharmacology, and also from the device side. They have improved a lot over recent years, and we can treat many more patients, but also there we need to gain additional safety, and we are still working on this. Thank you very much.